Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Ethan. How are you doing today?
Doing great. Thanks, Dennis. Appreciate being on.
So the reason why I invited you on is you posted a very scandalous post on Instagram, and I want to rake you over the coals for it. So
bring it on. Sounds good.
But your post kind of called into question, like, should we be doing just finger thoracotomies? I guess what posed that question?
Really, I did want to do exactly this, of stir the pot a little bit. I know a lot of people are looking at what do we do for chest trauma in the pre-hospital setting? What's the optimal protocol and where do we go from here? I know Kotze's, putting it to vote of what's the updated protocol going to be. I've talked with a lot of the guys involved in that. I thought it was an interesting article. I think looking at the comments that got taken, that wasn't exactly my intent, to say, hey, nobody should ever do a finger thoracotomy. This is garbage, stick with Neil. That wasn't my intent. So fully understand there was issues with the study. But I think my main point is, let's keep this conversation going. And there may not be this wonderful universal protocol that works for everybody all the time. And it may be that we don't have it figured out yet. And it may be that different patients require different protocols. It may be that different providers have different protocol sets. But I think it's an interesting article to look at and consider along with the rest of the data that's out there.
So, I guess why is there, we have three options when it comes to dealing with a tension pneumothorax. And I think people have to remember, that's the main reason why we're doing anything pre-hospital in the chest. You have a tension. We're not trying to relieve a pneumo or, a small hemo. They have tension, they're going to die. So, I guess why is there a bunch of question marks still?
Yeah, well, part of the problem, right, is you can't see through the chest, right? It's kind of this mysterious black box that if something goes through at high speed or even low speed, you're not sure what's going on. And the other problem is that, like we were talking about earlier, you can have hemorrhagic shock present very similar to tension pneumothorax. And obviously hemorrhagic shock kills a lot more patients on the battlefield than pneumothorax does. So that's always been a bit of a distractor of, hey, what's going on? And in my opinion, a lot of times when we were teaching pneumothorax and we were decompressing, it was kind of like, this is a quick, easy procedure that I have a tool for, so let's give it a try. And really it was hemorrhagic shock that was causing the vital sign decline in the patient. But that was before we had whole blood and TXA and everything like that. It was like, let me go ahead and decompress the chest. And also there was a training scar that a lot of us put into people, because every single time we ran a medic through a lane, they were going to get the tension pneumothorax. They were going to get it within a minute or two of the injury, which is totally unrealistic. But we were trying to maximize the training value of the patient. And so we were putting every single injury in there. So we trained medics and we trained pre-hospital providers. We gave them training scars that if your patient gets injured in the chest, they're going to develop a severe pneumothorax. It's going to happen really quickly. And once you put a needle in, they're going to be great. So it's this positive reward of, now all of a sudden my patient's doing better because I put a needle in the chest, whether that was the problem or not. I think we got better at that as time went on, to focus more and more on DCR. And I know the guys are doing a lot better job than we did, 10, 15 years ago.
Yeah, absolutely. And especially that instant gratification of you put the needle in, you get this giant whoosh of air, and the guy buttons up his shirt and is like, thanks, Doc, and rejoins the battle,
Excellent job, doctor. Let's move on. Time for tea.
But
Yep, absolutely.
so this paper kind of centered around the events going on in Gaza. So it was from the IDF, their trauma registry. So if you wouldn't mind, maybe let's start kind of walking through this paper.
Yeah, so it's interesting, right? There's not a lot of data. There's not a lot of high quality data on needle decompressions, finger thoracostomies being done in the pre-hospital environment. If you go to conferences, and Jen Gurney has brought it up multiple times, of that data is really tough. And in fact, last week I was talking with Russ Coatwall, who's pulling more data on needle decompression, and it's tough because if you go to like the post-morbid data, if you go to the autopsies out of Dover and you look at that, if you put a needle in someone's chest, it's really hard at that point to tell, did they actually have a tension pneumothorax at the time, right? So the data that we have at most is, did they get a needle? Did the needle actually make it to the chest? And then you got to try to make some assumptions off our poor collection of data. So I would argue that data for military pre-hospital chest trauma is not great, right? So all these little studies you're going to see maybe don't have great data. So that's where you got to go, okay, we're not going to totally change our practice. And I'm not saying we should change our practice based off an N of 8, like in this study. But when you get data, I think you need to take a look at that and say, what does this really mean? Does it apply to my patient population? Does it apply to my setting? And then take a look. So basically what they did is they took, what was it, around 4,500, 5,000 casualties over that first year. And then they isolated out chest trauma. And then of chest trauma, they looked at which got interventions. And then they basically broke that down and pulled out the 8 finger thoracostomies that were done in the pre-hospital environment in the first year. So they took all 8 of those and said, okay, what was the outcome and what did it look like? Interestingly enough, it was not in their protocol to do that, but it was physicians doing it in all 8 cases, which we all know we're not good at following directions and following protocols. But it's also a very small N, so we don't know fully what was going on at the time. And if you're a civilian physician and someone loses vital signs and you do a finger thoracostomy, I think that's absolutely appropriate. And it's done all the time in trauma centers. So really kind of interesting look of how that data even got there in the first place. And then they take those 8 and kind of break down what happened with each. And then I think there are some interesting things in there. I mean, I think it was half of them didn't even have penetrating chest trauma. Again, that's fine. You lose vitals, and sometimes you get lucky and you do a finger thor and you bring them back. So I think that was interesting. And then there was the one patient that got the infection. By no means do I think you can extrapolate that out, but that's been a concern of finger thoracostomy in the pre-hospital environment. I absolutely agree it can be done cleanly, potentially sterilely in the pre-hospital environment. But I think there's also a risk there, right? Anytime we go cutting into a patient, now you may say, whatever, they've got penetrating trauma, they're going to get a bunch of antibiotics. IDF is a very short evac time. So is it really that big of a deal? Well, in one patient it was. And the interesting thing with that is that patient got bilateral finger thoracostomies. So right side, left side, one of the sides had the penetrating trauma from, I think it was fragmentation. It was the contralateral side that got the infection and required, I think, a small resection. So I don't think that's definitively says, oh my God, we can't do it. It's such a dirty environment. Everyone's going to get an infection. But it is kind of interesting to see that, okay, of the 8, one of them did. And I think it's something to consider. Again, you've got to be alive to get an infection. And I totally get that. And the patient lived and they made it. So, hey, good on you. But it is something that as we start changing protocols and we start putting new protocols out there, we need to consider, and we definitely need to consider that in the training.
Yeah, absolutely. I mean, our guys, like, making sure that they put gloves on is not always the easiest thing, because nobody's rolling on a patrol with their micro gloves on. Sweat to death. But taking the time, get your gloves on, clean the site well. I mean, that's almost a hurdle in its own, just to get them to do that, because it's, everybody, we also, not only do we develop tensions like amazingly rapidly in all our training, but we also throw time on top of it. Like it's, this procedure can't be successful if it's not done within 5 minutes of recognition of, symptoms. I guess I don't really understand that, why we do that necessarily, other than just to put more stress on somebody. But I think that might be another training scar, that we force them to not utilize their tools to do a good assessment just because of time.
Yeah. Yeah. How many times we've said that the helicopter's inbound, you got 1 minute to wrap them up, rather than taking a few more minutes and saying, okay, let's do a really good assessment of the patient. You did an intervention. Are you positive it was successful? Let's reassess. Let's pause. And then honestly, what I like doing too with training is, and then you just sit there and let them sit with the patient and think through. And sometimes that silence is really, really impactful in training, because now it's like, okay, you do have time to think. I mean, pre-hospital treatment of casualties in war isn't always this crazy fast, hectic, bodies flying everywhere and, yard sale of equipment and helicopters landing and taking off. Sometimes it gets real quiet after the shooting stops, and it's like, okay, I got 20, 30 minutes, or I got some time to sit on this patient, and some of the times it's like, I've got hours to sit on this patient now, or days. So
yeah, now what,
Yep.
Yeah. And I think we're training good medicine, and obviously, like, at least the course that I train at, like, it's the best in the world, as evidenced by everybody sending people there to get trained on this. But we still train them to do, if A, then do B, then do this procedure and then move on, versus, how do you really assess your patient? How do you figure out what's killing this person, and now using that information to direct your therapy? It's just put tourniquets on, drop needles. Did you crike them yet? Probably should crike them. And just do as many procedures as you can.
Yeah. And that's why, too, putting emphasis on diagnostics, right? Like, is it hemorrhagic shock, or is it pneumothorax, and being better equipped and trained to differentiate that out. That's why I'm excited about, AI and ultrasound, and how much easier ultrasound is getting. I mean, now there's that one group at Soma Deep Breathe, and I don't know if you saw them at the booth, but it's pretty interesting. You put the butterfly probe on, it tells you if you're in the right spot. You give it like a second and a half, maybe 2 seconds, and it's green light or red light. So stuff like that, like, no longer do you have to, we're getting to that point where no longer do you have to, most importantly, guess, is there a tension pneumothorax or not? And then also, we don't have to send medics to a, week-long ultrasound tech course, and then once a month you're spending a full day doing that as well too. We're moving towards that point of getting better diagnostics that are smaller and more accurate in medics' hands, so it'll help them differentiate out the two, versus being cold, alone, afraid, and like, man, I don't know, maybe I'll try jabbing this really sharp needle in this patient's chest and see if they get better.
And I mean, and everybody kind of throws this out, that there is such a thing as a diagnostic finger Thor, or a diagnostic needle decompression, which is true. However, they're diagnostic because you actually have a suspicion. You're not just throwing darts at the wall and hoping you guess right.
Yeah.
But like, I guess what would be the risk? Let's say we have somebody who is in shock, hemorrhagic shock. They have some kind of indication that there's some kind of chest trauma. Whether it actually penetrated or not, like, I have no idea. I just see some holes on the outside. And I do a finger Thor. I guess what could be the negative consequences to that?
So you get basically a diagnostically negative finger Thor. So first of all, I think that's a great point. Finger Thor can be really helpful diagnostically. Like it's very easy to tell. It's more accurate, right? Because it's easy to tell you're in the right spot because you got your finger up there and you're sweeping the pleural cavity. It's like, that's pretty obvious. Still not 100%, but you can still screw that up. But that's pretty obvious. So I think the advantages, first of all, in it is, one, it's a good diagnostic, right? If you see blood running out of the chest, okay, I need to start pumping blood into this guy and get him the hell out of here as fast as I can. So one, I think it's good for that. Two is it's a great way to relieve a tension pneumothorax. It's fast, requires minimum tools. I mean, depending on your technique, you don't even need the pins. You can just scalpel down and go. I was talking to Andy. That's how he's doing it. He's like, I can just scalpel down, pop in into the pleura, and I'm good. I know what's in the chest. I know I've relieved it, and I can move on. So I think that's a good advantage to it. Disadvantage, you can still screw it up, right? So you can cut too low and bury some pins in a liver or a spleen. You can, if technique's off, you can do some damage to the lung, potentially induce a little bit more bleeding. Ideally, you're training properly and you know how to do it well. And then there is an infection risk. I mean, anytime we open up a patient, we do a procedure on a patient, there's some sort of an infection risk, especially when you're cutting skin and you're cutting through layers. So there is that risk. And then there's the question of, now that I've done it, what do I do next? Right? Am I prepping to put a chest tube in? Am I just leaving it and then I'm going to cleanly burp it if they, stick my finger back in, if they have symptoms again, and hope, but then the more and more I'm putting a finger in this person's chest, the more I'm inducing risk of infection down the road. So it's, by no means do I think I have the absolute right answer on it, but it's a tough situation. I think there's advantages of both. I think a lot of it depends on your training level, your provider level, and then obviously your patient and what you're seeing.
Yeah. And I think, context is absolutely everything. You have a patient who is slowly declining. Probably my first thought would not be shoving fingers in both sides of his chest. Yeah. We have some time. Let's do some other interventions, maybe give him some more fluid. There's a bunch of maybes that I get to before finger Thor. On the other hand, I have somebody who's rapidly declining. I don't have lots of time. Even knowing, I think it's super important to know, the risk benefit. Like, this guy is going to die in the next couple of minutes if I don't do something. I guess I would err on go big, decompress the chest. If I'm wrong, then I know for certain he just needs more blood, which I should be calling for more anyway, if I don't have any. And if I'm right, I fix the problem.
Yeah. And you're keeping your eye on that big picture of the most common way to die in combat, as has been for centuries and centuries, is bleeding out. Like, that's the majority of the problems. I mean, definitely there's deaths from other causes, but common things being common, you need to focus on hemorrhage control and resuscitating with blood products.
Yeah. So kind of going back to this study, of the 8, like 4 of them died. They died from traumatic cardiac arrest. And let's see, almost all of them got bilateral finger Thors. So obviously it got bad quick. Yeah. I would take that to mean you were dealing with a really sick patient, regardless they got the finger Thor or a needle D or a chest tube. It could have gone that way anyway. Yeah. So do you think it's really fair to add those patients to a study to determine if this procedure is successful or not?
No, I don't. And I think that's a great point. Like years and years ago when I was in residency and I did my trauma rotation down at Miami, right? That was, you go up, you meet the patient on the helipad. If they lost vitals en route, you would do bilateral finger thoracostomy and hope that that relieves some tension pneumothorax and they got vitals back and you could save the patient, right? Yeah. So you had a lot of dead patients getting finger thoracostomies, right? And so I agree with you that like that's a last ditch effort. That's not a specific intervention for a known problem that they could potentially come back from, right? Like you get a transthoracic gunshot wound and you go through the descending aorta, whatever, like your finger thoracostomy isn't going to save anybody doing that when their aorta is punctured and they're bleeding out, right? So I agree with you. I didn't look at this study as like how often does it save a patient's life? Like, cause there's so much more involved in that patient. So that's the tough thing I think of that study. So those 4, I kind of looked at that and I'm like, okay, they died and they got finger thors just to make sure they didn't die with a tension. And that's taught all the time. I mean, I taught my medics at regiment was, if they lose vital signs, go ahead and do a finger thor. I mean, you got nothing to lose at that point. And then you never want a patient to die with a pneumothorax, with a tension pneumothorax, right? I mean, there's should be no reason for that. So
I guess, I mean, other than just a good study on how to read a research paper, because the way the way I felt that they wrote this paper is like trying to call into question this procedure at all. Essentially, it's like, well, it's not any more effective than anything else, so almost don't do it.
There definitely was a hint of that in there. That wasn't necessarily my takeaway. When we talk about the bilateral finger thor in someone that has lost vitals, it's almost like the supraglottic discussion of only dead people are getting supraglottics. So why are we even doing supraglottics? And I think you got to be careful to not make that same analogy on this one. But I definitely, when I was reading that, I was like, okay, I don't know that necessarily means we throw that out. I just think there's some considerations in there that as we do our protocols, maybe it is do needle decompression first because it's less invasive, obviously with the assumption that you're using the right equipment and you're trained properly and you're doing the procedure correctly in the right spot, which I understand is a big assumption, unfortunately. But then maybe it's you do that, hopefully verify it with end-tidal CO2, right detector that you can do after your needle D or your chest tube. And then if that's not working and you feel like you're maximizing their blood product resuscitation, then, and hey, they're still not getting better, then maybe, okay, now we go to it. So I don't know. It's this pendulum that we're always on of tourniquets on everything. No, we got to start getting rid of tourniquets on everything. And the pendulum just swings back and forth. So are we doing that with needle decompressions? Oh my God, we needle decompress the hell out of everybody. And I agree. I think we had too many on one end of the spectrum and they were getting put in the wrong spot. So it's probably time to do a better job diagnostically, making sure we're only penetrating the chest in our patients with patients that need it, and trying to be as accurate as possible. But on the other hand, you start swinging too far. I don't want to come back to the, did we lose patients from tension pneumothorax?
Yeah, I think it almost seems like human nature to want to buy your way into success, right? And especially Americans, like, can I just buy the thing that will work and I'll just never have to deal with death ever? I understand the weirdness in that you work for a company that's what they do. But the answer always seems to be train them better and you'll have probably better outcomes. Same as a tourniquet. we put tourniquets on everything. Now people are losing limbs. Well, did you teach them how to take it off?
Yeah. You tell them to put it on. Probably a good idea to. Yeah, and I think that's a great point. I mean, obviously, like we discussed, I work for North American Rescue. I have inherent bias in that, right? Now I don't get commission off sales or anything like that. And I'm fortunate in that my job, I get to do a good amount of training with our training company. And I definitely training is way more important than equipment is, 100% all day, every day. But then on the equipment side, I get to focus on trying to make sure that we're coming out and using products that are helpful, that the instructions are clear, that we're educating the public on the best way. Great example is needle decompression, right? The reason why we put those centimeter marks on is because people were going too far and they were bearing to the hub, like the DoD has said to do for years, right? But our instructions for use have been, do not bury to the hub, right? It is hit the rib, go no more than 3 centimeters past, and do it in a safe way. That's why we have those markings on there. And so a lot of my job has been to try to get that education out there and teach people, I know, and I hate to go against COTC. I was on COTC and now they fixed it, but do not bury to the hub. That is very, very dangerous, right? And so I don't want people using products just because they're NAR products or whatever. I want people using products that are going to help save lives. And if we can bring something out that's going to help someone, then awesome. Some of the stuff isn't game-changing, life-saving, it's a new nylon pouch to, carry something in, fine. But I really enjoy the stuff where we're trying to make a medic's life easier and, most importantly, save lives. And then the sales stuff that works itself out when you're focusing on the right stuff.
Yeah, absolutely. And I was kind of just joking about pimping gear and stuff, but that does seem like
you got to watch who you're listening to. And everybody listening right now should know I work for North American Rescue. I'm not trying to hide that, but I'm also Ethan Miles, a doc that really cares about saving lives pre-hospital. And I care about that more than I do my paycheck or that company. So,
yeah, which is absolutely why I asked you to come on. But, and it's not like, evil companies, it's the governments, it's different entities versus putting money into training. I'll put 10 times more money into buying the latest thing, and you're still almost in the same spot.
Yeah. And Andy Fisher and I talked about that a little bit last night. And as a whole, our community, we're gearheads, right? We love the newest gear. And we tend to be early adopters, especially in the special operations and medic world, not so much in the doc, medical provider, med director world. That side sometimes is very takes forever and ever and very late adopters, but you got to be careful. I mean, new medics, me included, but there's this tendency to want to just jump at the next thing, whether it's a technique like a finger thoracostomy or whether it's the next product that's coming out. It's let me jump on that because I want to be the first one to get case use, save a life, write a paper on it. I want to be that guy that,
it's a status thing.
Innovator, the adopter, right?
Yeah. So, it's a status thing for certain.
Oh yeah.
I want to seem like I'm the on the bleeding edge of everything. Yeah. So that's why I carry.
I love how this whole community is just innovating, trying to get to the next best thing, save patients' lives, and then share it. You want to be at the next conference of, hey, we figured out this awesome thing and you guys should do it too. And that's a great thing about the community, but sometimes you got to do it with a little bit of caution because it's hang on, wait, maybe that's not the next best thing. Let's pump the brakes a little bit.
So you mentioned data. Data is just hard to come by. One, God forbid, medics like me would write it down. But say you're king of data for the day, and you can collect whatever, however you want to. how would we collect data to be able to determine, finger Thor versus needle D versus like to narrow that down?
Yeah. So if I was king for the day and the big assumption was I could make anything happen, um, I would enact what Tatrick's been working on, and I would combine that with what JTS has been working on. I think that to get the purest, best data, if you had pre-hospital providers that did not have to do an extra step of anything, and that data was being recorded automatically. Patient vital signs before their injury, during their injury, afterwards, right? That was just automated, whether you're wearing some sticky patch or whatever. And it's a lot of assumptions, assuming that actually provides quality vital signs and all that. And we know exactly when procedures were done. We know rates of infusion. We know drug delivery times. We know injuries. I think that would be amazing. Like the casualty cards that, you and I did back in the day, it was a wild guess the majority of the time. What was their respiratory rate? And you're like, 16? Like, I think I kind of wanted it to be because that would match the treatments that I did. So that vital signs garbage, that vital signs data was garbage, right? I mean, it just, let alone truly trending that. You're not really trending that. I mean, maybe you get a pulse initially, but they're in a lot of pain and then they're not as much. And so it's kind of going all over. So it's really hard to get that data. And the last thing we want to do, we want good quality data, but we don't want to pull a medic off of doing his job of saving a life. Right. And so they can't just stop, be like, hang on, I got to get my clipboard out. And, while the patient's dying. Now, later on in the prolonged setting, I got it. Yep. Absolutely need to hit that point where we're collecting quality vital signs. But I think I would do automated, Tatrick's interested in, can you use it for medical logistics and everything of what procedure you're doing? But if we can know what procedure when, and then you can combine it with diagnostics that are getting better, like ultrasound, right? Did they have lung sliding? No lung sliding. They did an intervention. They had lung sliding, vital signs pop back up. Okay, great. That worked out well.
Yeah. Now, especially military, obviously kind of different than just like civilian pre-hospital. I mean, in 1 year in Israel, they got 8.
Yeah.
And it's like a very active war going on. They had 8 of them. How many data sets would you need to be able to come up with finger Thor or needle D?
And I don't know if that would be really interesting if we had thousands of needle Ds and thousands of finger Thors and who had better outcomes. The problem is to add on to that is the injury patterns are so different too. So, you can look at injury severity score. You can look, is it hemorrhagic shock? Is it confirmed pneumo and all this kind of stuff? But that's going to be so hard to pull it out to ever do a head to head. So I mean, maybe one day that we'll get that data, but I don't know that I don't think we're anywhere near of saying one is better than the other. And it may not be that we actually need that data to say which one. And I don't think by any means it's needle D or finger Thor or chest tube. I don't think you have to necessarily pick one. I think it's situation dependent. I think it's, level of provider dependent. It depends on the injury, not to try to make it too complicated. And eventually we need to get down to protocols that are pretty good. But, I think we look at different protocols, different situations. In my opinion, if you have a strong index of suspicion for a tension pneumothorax, especially if you can confirm, on ultrasound that there's no lung sliding, and I think it's still reasonable to do a needle decompression and then confirm that. I think it's a great idea if you're going to stick a needle in someone to use that cap no spot thing. I mean, we sell, shameless plug, being honest, we sell it. And I think it's really interesting to be able to now put a needle in a patient's chest and instantly look and see that it made it in the parietal pleura. Because the only way that CO2 is coming through that thing and changing the color is if you've made it into the thoracic cavity. So to me, that's like, put that needle in, see the color change, and freaking move on. Like, go back to your DCR protocol. So I could see that. And then maybe if they don't get better, you're in the cavity. Do we need to do a finger Thor, or I'm not hitting the cavity, so let's do a finger Thor, or I think it's blood, then boom. So I think there's room for both. I think each unit is probably a little bit different. There's some units that aren't ever going to be comfortable with their medics doing a finger Thor, right? They're going to be like, nope, put that scalpel down. And then, so they may just be a needle D only. And then there's going to be some more advanced units that say, hey, in general, these are the indications, but at a certain point, you got to trust your medics and say, hey, dealer's choice. Like, if you feel like it's the right thing to do, then I've trained you and we've run through scenarios and you do what you think is right.
Yeah. Awesome. I don't know. Is there anything else you'd like to talk about when it comes to finger Thors and pre-hospital?
No, I mean, hopefully that, clears a little bit up, but I think there's a time and a place for all three of those interventions. I do think it's interesting, like we brought up before. If we do say you're going to go to a finger Thor, then we also owe it to the medics in those protocols to say, okay, once you do that, now what? Right. So if your patient starts decompensating, what do I do now? Do I do another finger Thor? Do I clean it again, put my finger in there and try to kind of burp it? Do I stick a chest tube in at that point? Do I put that chest tube through the safe spot? So there's some stuff I think that we just got to think through. I don't think it's impossible to get through that, but I think just anytime we change protocols, you just really got to look at the second and third order consequence of changing that protocol. And then before you sign off and do it, run through it and run through different scenarios in the field so you know what you can expect.
Yeah. Awesome. Well, thank you, Ethan. I really appreciate it.
Yeah. Thanks, Dennis. Appreciate it. Good seeing you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.